Today's webinar is Stroke Management in Neurosurgical Perspective in Bangladesh. Dear audience, I am Dr. Mukherjee, Scientific Secretary of Bangladesh Society of Neurosurgeons. I am moderator of this webinar. This session will stay for 1 hour. Welcome speech will be given by Secretary Dr. Jainul Islam, Bangladesh Society of Neurosurgeons, followed by valuable speech of renowned speaker. Then panelists will discuss. Finally, audience, you can ask question through RAS TV chat box. Now, I will introduce Dr. Jainul Islam, Secretary, Bangladesh Society of Neurosurgeons. Dr. Jainul Islam, please, for welcome speech.
ধন্যবাদ ডক্টর সুদীপ্ত মুখার্জি। আমি শুরুতেই বলে নিচ্ছি আমি আমার স্পিচটা বাংলায় দিতে চাই সুবিধার্থে, সে কারণেই আমি বাংলায় আমার বক্তব্য তুলে ধরতে চাচ্ছি। বাংলাদেশ সোসাইটি অফ নিউরোসার্জনস এর সম্মানিত সদস্যবৃন্দ এবং রাজ টিভি, ডক্টর টিভির মাধ্যমে সংযুক্ত দর্শকবৃন্দ, আসসালামু আলাইকুম। বাংলাদেশ সোসাইটি অফ নিউরোসার্জনস কর্তৃক আয়োজিত বিশ্ব স্ট্রোক দিবস 2020 উদযাপন উপলক্ষে অনুষ্ঠিত ওয়েবিনারে আপনাদের স্বাগত জানাচ্ছি। আজকের ওয়েবিনারের মূল লক্ষ্য হচ্ছে বিশ্ববাসীর পাশাপাশি দেশের মানুষকে স্ট্রোক সম্পর্কে সচেতন করে তোলা। আমাদের মাঝে উপস্থিত আছেন বাংলাদেশ সোসাইটি অফ নিউরোসার্জনস এর সম্মানিত সভাপতি ও বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটির মাননীয় উপাচার্য অধ্যাপক কনকান্তি বড়ুয়া, বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটির নিউরোসার্জারি বিভাগের চেয়ারম্যান অধ্যাপক এটিএম মোশাররফ হোসেন, ন্যাশনাল ইনস্টিটিউট অফ নিউরোসায়েন্সের সাবেক অধ্যাপক শেখ সাদেক হোসেন। বিশ্ব স্ট্রোক দিবসে এবারের প্রতিপাদ্য হচ্ছে জয়েন দ্য মুভমেন্ট টু প্রিভেন্ট স্ট্রোক, অর্থাৎ সচলভাবে সুস্থ থাকি, স্ট্রোকের ঝুঁকি দূরে রাখি। স্ট্রোকের ঝুঁকি দূরে রাখতে আজ আমাদের আয়োজন ওয়েবিনার ফর স্ট্রোক ম্যানেজমেন্ট ইন নিউরোসার্জিক্যাল পার্সপেক্টিভ ইন বাংলাদেশ। এই ওয়েবিনার প্রোগ্রাম পরিচালনার জন্য সোসাইটির সায়েন্টিফিক সেক্রেটারি ডক্টর সুদীপ্ত কুমার মুখার্জিকে অনুরোধ করছি। মাইক্রোফোন হস্তান্তরের পূর্বে আমাদের মিডিয়া পার্টনার রাজ টিভি এবং ডক্টর টিভিকে অনুষ্ঠানটি সম্প্রচারের জন্য ধন্যবাদ জ্ঞাপন করছি। উপস্থিত সম্মানিত সদস্যবৃন্দ এবং স্পিকার বৃন্দ যারা রয়েছেন তাদেরকে আমি আমার সোসাইটির পক্ষ থেকে ধন্যবাদ জ্ঞাপন করে আমার বক্তব্য শেষ করছি। ধন্যবাদ।
Thanks, Dr. Jainul Islam. Now I will invite Dr. Professor Dhiman Choudhury, Professor, Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University. His speech is Stroke Management, a Neurosurgeon's Challenge. Dr. Dhiman Choudhury, please. Professor Dhiman Choudhury, please.
Yes. Am I audible?
Yes.
So thank you, Dr. Sudipta Mukherjee. Very good evening to everybody. First of all, I want to pay thanks to Bangladesh Society of Neurosurgical Society for inviting me and giving space to give a talk on, to say a few words on stroke and for as a part of stroke management awareness in Bangladesh. Here is present all the panelists, renowned panelists, our beloved teacher, our chief patron of Bangladesh Neurosurgical Society, Vice Chancellor, and our ex-chairman of Neurosurgical Department of Bangladesh Sheikh Mujib Medical University, Professor Kanakanti Borua, present chairman of Bangladesh Sheikh Mujib Medical University Department of Neurosurgery, Professor ATM Mosharraf Hossain sir, and Professor Sheikh Sader Hossain, ex-chairman, National Institute of Neuroscience. Take my best regards. I'm very happy. There is a beautiful discussion will be held today with our other speakers, Dr. Shafiqul Islam from Dhaka Medical College, Dr. Colonel Alamin Sheikh. So, stroke management nowadays become confused by the doctors and doctors community in Bangladesh. So, as because who will treat which type of stroke become confused. To me, stroke should be treated by everybody, and some primary knowledge of stroke should be known to all the doctors from junior to seniors, even with the paramedics also. As because strokes are attended as a first attending doctors or the junior doctors are attending, even some in centers, even in the rural area, the paramedics are attending the this kind of strokes. So timing treatment of strokes is very important. So awareness of stroke is very important. So I want to share my screen. I think you can see my screen.
Yes.
Yes, sir.
Yes, sir.
Okay.
You can see.
So my topic is short stroke management and neurosurgeons challenge. This is the slogan of this year, World Stroke Day, join the movement. So stroke is defined as a rapidly developing focal or global neurological deficit, which is non-traumatic vascular in origin and lasts for more than 24 hours, or patient dies within this period. Another terminology is the transient ischemic attack is intertwined with stroke. Transient ischemic attack has similar symptoms like stroke, but lasts less than 24 hours. It often a warning sign of future strokes. About 1 in 3 people who has a transient ischemic attack will eventually have a stroke, with about half occurring within a year after the transient ischemic stroke. Some demography. Asia holds 60% of the world's population and comprises some developing countries which are in economic transition. So the stroke management is still lagging behind from Western world, leading to more mortality, disability, and socioeconomic burden. Demography of stroke is mainly include incidence, prevalence, mortality, and disability adjusted life years. That is DALYS. It is very important. Lost because of stroke. DALYS, that is disability adjusted life years. It means when a patient has a stroke and he has lost his work, so it means the fruitful time wasted during his stroke period. It is very important in for calculating the economic burden due to stroke. There is some 2013 globally there was nearly 25.57 million stroke survivors, 6.5 million deaths due to stroke, 113 million disability adjusted life years lost because of stroke, and 10.3 million new cases of strokes. A majority of strokes burden was observed in developing countries, accounting for 75.2% of all stroke-related death and 81% of the associated DALYS lost. There is some comparison, incidence, prevalence, DALYS, and mortality. The incidence, the highest incidence in Japan, but they have a very good management system. So in prevalence, they are still already hidden. That is, in prevalence, Pakistan is highest. Prevalence means from the day one of data collection till today is called prevalence. And the lowest in Asia, that in incidence, is Malaysia. Bangladesh, no data was found. In Europe, 220 in per lakh or per 100,000 patients. Disability adjusted life years lost in Mongolia is the highest, and lowest is Japan. Bangladesh is 888 per 100,000. It is even in better than the Europe. Mortality highest in Mongolia and lowest in Japan. Some Bangladesh perspective. Stroke is the third leading cause of death in Bangladesh. Bangladesh's mortality rate due to stroke is ranked in the world ranking. It is 84. The reported prevalence of stroke is 0.9, and the incident is not. There is no data. Hospital-based studies conducted in past decades has indicated that the hypertension is the main cause of ischemic and hemorrhagic stroke in Bangladesh. The higher number of disability-adjusted life years lost due to stroke is 888 per 100,000. So the stroke severely impact Bangladesh economy. So establishing a tertiary dedicated stroke center is needed to cope this disease burden. It is time demand. Types of stroke we know well. It is very just recapitulation: ischemic stroke and hemorrhagic strokes, which one is 85% and 15%. There are some risk factors. Some as non-modifiable risk factors. This we know, whether age, gender, race, ethnicity, and family history. We cannot do much about this. But there are some modifying risk factors. That is hypertension, cardiac disease, diabetes, hyperlipidemia, cigarette smoking, alcohol consumption, drug abuse, lifestyle, that is obesity and lack of physical activity or poor diet, oral contraceptive, migraine, atrial fibrillation, and transient ischemic attack. All are the risk factor. It is combatable. This is some cartoonic or schematic presentation. And see, if you'll see, there is a patient is waiting in front of the doctors and denoting a lot of numerical things. He's very happy. Doctor is telling that, oh, the number has nothing to do with the lottery or the stock market. That is only your cholesterol level. That is high cholesterol level, which leads to stroke in any time of his life. So the remedy is at least 1 hour a day the exercise. Otherwise, being dead 24 hours in a day, any time or any hour, we can have some this stroke problem even after 50. Etiology: ischemic stroke, embolism, and thrombosis. Embolism may be cardiac, arterial, or cryptogenic. That is, causes are not clear. And thrombosis is arteriosclerotic plaque in common carotid artery or carotid bifurcation or internal carotid artery or any branches. It is obstructed by this thrombosis and leads to ischemic stroke. There's other important thing: hemorrhagic stroke may be due to hypertension, cerebral amyloidic angiopathy, vascular malformation, or aneurysm, and abnormal drug abuse. It's cocaine, amphetamine, and anticoagulant. They may lead some arterial wall damage. Hemorrhage in tumor, hemorrhagic transformation of stroke, even ischemic stroke also. Someone is doing some abnormal works. I don't know who is doing. There are some schematic stroke presentation, pathogenesis of stroke. That is, sorry. There is a small artery occlusion or large artery occlusion more than 50%. Carotid artery embolization may lead to cerebral reduction of the cerebral blood flow. I'll not go for total this flow chart, giving some outline of this. So reduced oxygen and glucose in infrared location leads to anaerobic metabolism, reduced to ATP, lactate increase. Finally, this will lead to sodium potassium ATPase pump, hampering the sodium potassium ATPase pump. So sodium is kept inside the cell, which leads to imbibition of water, leads to cell damage, and release of glutamine from neuronal cells, which leads to finally necrosis, secondary inflammation, and when there is lactate, there is primary inflammation is going on, which finally all leads to some symptoms due to neuronal deficits. Similarly, in the pathogenesis of hemorrhagic stroke, the amyloidic amyelopathy, hypertension, vascular malformation, or all aneurysm leads to vascular wall rupture, leading to bleeding and at side-by-side intracranial pressure by hematoma. This released blood has some toxicity, and sudden focal intracranial brain trauma from hematoma leads to mass effect. The RBC sliced, and from lysed RBC, cytokines, cytotoxic hemoglobin, and other cytokines is released, leads to necrosis of the neuronal tissue. Similarly, as the previous slide we saw, the reduced ATP and increased lactate will got the similar symptoms in general findings: nausea, vomiting, headache, seizure, and increased. If there is increased ICP, leads to papilledema, sudden headache, non-reactive people, and decreased level of consciousness. All these neurological symptoms will get. This is in nutshell. Ischemic stroke. In ischemic stroke treatment, time is very important. In less period of time, we can save a great area of brain involved ischemic stroke. So the treatment aim is to recanalize the blood vessel which is blocked, prevent prognosis of present events. It prevent immediate complications, prevent the development of subsequent events which may develop in ischemic stroke. That is, we know it is a penumbra. We can reward it, and also treatment includes the rehabilitation of the patient. It is this slide will seems to be very clumsy, but if I give some concentration, it give an action plan of ischemic stroke. I try to make it simplify. As when the patient is stroke patient come to a ward or emergency department. Sorry, there is some disturbances. Assessment, clinical assessment, and by GCS, and there is National Institute of Health stroke scoring. I'll explain in later slide what is NIHSS and the timing. And side by side, some investigation is also needed. That is RBS, random blood sugar, as because there is some hypoglycemia leads to stroke-like symptoms. As because we'll go subsequently for intravenous TPA. If there is hypoglycemia, will not go for TPA later on. So it is very simple, but it is very informative. And side by side, we'll go for these. Assessment protocol was based on American Health Association, American Health Stroke Association. So after assessing clinically, we send the patient for non-contrast CT to confirm whether it's hemorrhagic stroke or non-hemorrhagic or ischemic stroke. If it will be hemorrhagic stroke, and then we'll go for other treatments. If it is ischemic stroke, from the CT, if it is within 0.0 hour to 4.5 hour, and with NIH stroke scoring below 5, I'll explain it later. And the aspects, that is, it is other scoring system based on CT scan and pre-stroke modified ranking state, which denotes whether patients have some stroke problem earlier before it may be a second stroke. If it is pre-stroke, it is more than 1. It is the good candidate for mechanical thrombectomy. But if there is no facilities of mechanical thrombectomy, then we should go for intravenous TPA, the alteplase. If the patient have pre-stroke more than 0 to 1, NIH score is more than 6, and this aspects is more than 6, and age is more than 8, we'll go for CT, and side by side we'll go for CT perfusion. In our center, in our Bangladesh, it is not available in everywhere, but we'll make it available to make a total planning and proper treatment of the stroke. So it indicates final occlusion. From these stroke scoring system, we can gauge where the stroke is, where the occlusion is. If it is the main branch of ICA or M1, and it is less than 6 hours, the final good recommendation is to go for endovascular treatment, which will be explained by our beloved Dr. Shofiq. I think he will explain later on. If it is 6 to 16 hours, there is other scoring system that is Dawn and diffuse scoring system. Recommended dose again endovascular treatment. If it is less than the time is more than 16 to 24 hours, there is other scoring system, diffuse. There is level 2 recommendation, that is the risk benefit is almost similar, but level 1 is benefit is more than risk. Again, we can go for endovascular treatment. Similarly, in the peripheral vessels, that is M2, M3, posterior circulation, we can go for endovascular treatment, but benefit is uncertain. It is level 2 evidence. Now if the timing is more than 6 hours, but patient is not candidate of mechanical thrombectomy as the age is increased, we can go for conservative treatment. If according to the 2018 American Heart Association guidelines, and suddenly if during this period when there is severe post-admission neurological deterioration or clinical based or CT based evidence of complete ICA obstruction or MCA infarct, and patient age is less than 70, we can go for emergency decompressive craniotomy. It seems to be clumsy, but if we'll give a concentration, and all the scoring system should not be memorized. All this is kept in the OR emergency department, and junior doctors can easily handle it properly. So in this posterior fossa, suboccipital craniotomy must be done as soon as possible if we'll get a posterior fossa hematoma. This is a guideline for conservative. It is as a short note, it is written everywhere as a short list. A junior doctor can read all these things and check. It is one kind of checklist. Now come for the recanalization. Recanalization by medical agents, plasminogen activator, or thrombectomy. If it is timing is within 4.5 hours, we should go for, and the score permits, we should go for chemical thrombectomy. We can also go, if the score also permits and time is within 24 hours, we also go for mechanical thrombectomy. This is NIH stroke scoring. This total scoring is 42, sorry. This is based on 11 headlines, and scoring is 0 to 1, 0 to 3, somewhere. Final score is there. If the score is more than 10, it is not good. This pre-stroke modified ranking scale, it is a follow-up scoring system of previously stroke patient. It is also important. This is aspects is based on CT scan. That is, it is very simple. I can have a slice of axial CT scan at the level of the thalamus, and just above the level of the thalamus. There is a 10 scoring area for the normal patient. One is for caudate nucleus, one is for lentiform nucleus, one is for internal capsule, other is for external capsule. This is 4. And from the territory of MCA, that is divided for 6, 1, 2, 3, and just above 4, 5, 6. If anyone, this is an example on the opposite side, if there is this area is involved, one is less. So this is dawn and diffusion scoring system. Now come to the CT scan of cerebral vessels. When we do within 0 to 24 hours, where the pre-stroke modified ranking stage 0 to 1, NIH ranking score is more than 6, aspect scoring is more than 6, and age is more than 18. We should go for CT angiogram side by side with CT, but it is in the second phase. We can go for CT perfusion in the lateral phase. It is CT perfusion based on mean transient time, cerebral blood flow, cerebral blood volume. In gray matter, mean transient time is 4 seconds, cerebral blood flow is 16 in per 100 gram in per minute, cerebral blood volume 4 ml in per 100 gram. White matter, you see this mean time is 4.8 seconds, cerebral blood flow is 25 milligram in 100 ml, 100 gram of tissue in per minute. Cerebral blood volume is 2 ml. It is the normal. This is the CT perfusion. It takes less time than the MRI. So it is in different centers recommended CT perfusion for proper management of the stroke. This slide showing this is the amount of blood flowing. This slide showing the movement of the blood flow. And finally, we'll get a picture. This is the core of main infarct zone, and this is the penumbra zone. The ischemic penumbra is the surrounding area where the increased mean time, transient time is increased, and there is moderate blood flow, that is 20 to 50 ml of 100 milligram gram of brain tissue per minute. And there is near normal or increased cerebral blood volume. But the core tissue, see, increased mean transient time, that is transient time going to the blood is taking long time. And marked decreased cerebral blood flow, that is below 16. Below 20, there is chance of ischemia, and below 16, there is the tissue is going to be infarct. There is a comparative pictures of CT perfusion and MRI. Sorry, MRI. That is, we can see the non-contrast CT, perfusion CT. We can see the core and penumbra. When you go for CT angiogram, we can see there is obstruction of the blood vessels. In some centers, most of the higher centers, they prefer CT perfusion instead of MRI, as because it takes less time and we can save the golden time. In stroke treatment, this mechanical thrombectomy, this is a tube. It will be described later on by Dr. Shofik. This is some schematic presentation how thrombectomy was done. So now overview of surgical management. Eligible for mechanical thrombectomy by Fogarty balloon catheter, embolectomy or stenting. If there is cerebellar infarct, we should go for suboccipital craniectomy. If there is massive MC infarct, we go for decompressive craniectomy. Where there is TIA or chronic insufficiency, we should go for carotid endarterectomy, or in some special situation, ECIC bypass. Sorry. Suboccipital craniectomy indication, the cerebral infarct leads to rapidly developing cerebral symptoms, and there is no response to medical therapy leading to brainstem compression. But when there is compression of the brainstem, it is give a good benefit. Whether the volume, whatever the volume of the hematoma, we should go for cerebellar infarct. But lateral medullary syndrome due to ischemia, previous ischemia, it will not improve by suboccipital cerebellar infarct. So before doing surgery, we should assess perfectly from the radiology. Massive MC infarct, it is very important. Ischemia of total territory of MCA due to obstruction of the trunk of MCA. It is 10% of total stroke patients, but here is mortality is high. It is about 80%. They present in CT's findings the major infarct within first 12 hours. Usually we know after second 12 hours or later on, we can see in CT scan more precisely. But in massive MCA, first 12 hours will get the almost zone of the infarct area. So most developed patient usually develop drowsiness after admission. You can observe it, and progressive deterioration during the first 2 days, and subsequent tentorial herniation. You can get it from the CT, subsequent CT, and it is happened within 2 or 3 days of stroke. So there is some other indications, that is the patient when will go for will detect is a massive MC infarct. Patient severely drowsiness, dense hemiplegia is about 50, around 50 or more. Early parenchymal hypodensity involved more than 50% within first 12 hours, and there is midline shift 8 to 10 mm, early SI effacement, and hyperdense artery sign in MCA. It is a beautiful sign. We can get it in MCA. The MCA is hyperdense in the MCA, in the hypodense area background. Management, when it is more aged patient who are not well candidate, we can go for conservative measurement, but mortality is in that case, it is very high. And other good option is the hemicraniectomy or decompressive craniectomy. Better outcome, mortality is less. Surgical indication in the patient with massive MC infarct, no firm indication was still there, but some guidelines is there. Age should be less than 70 and on non-dominant hemisphere, and there is clinical and CT evidence of acute or complete IC or MCA infarct, and direct signs of impending herniation or complete severe hemispheric brain swelling you can get from the follow-up CT. And there is severe post-admission neurological deterioration is the usual event in the trigger surgical intervention. There's some evidence examples. You can see there is a massive MC infarct. You see there is an midline shift and effacement of the same-sided ventricles. After decompressive craniotomy, it is regaining. We can get ventricle is. We can see the ventricle. There is midline shift is obliterated. It is become to the normal. Now come to the carotid and arterectomy. This is all the surgical aspects for the strokes. In the symptomatic patients where the stenosis is more than 50, but in low-grade stenosis, we can go for medical treatment by revascularization. In asymptomatic patients, into moderate to severe, it should be more than 60 for candidate for carotid endarterectomy. I think in the next speaker will explain beautifully and precisely. And you can see some examples of carotid endarterectomy clockwise, that is giving incision to the carotid, some fenestration and dissection from the arterial wall of the thrombus. Thrombectomy is going to be finished, and finally we are repairing the vessels. This is some figures, schematic presentation of carotid endarterectomy. Hemorrhagic stroke. Lesion, when we'll go for hemorrhagic stroke surgery, the lesion is marked, have a mass effect, is edema, pronounced edema, and a midline shift on the images that you will get it. Sorry. And the lesion have the symptoms. The lesions, with these lesions, and the patient has the symptoms of hemiparesis, orplasia, aphasia, agitation, and confusion, which is ultimately which leads to, we know this is the symptom due to raised ICP, due to mass effect from the clot or surrounding edema. And then we'll go for surgery for hemorrhagic stroke. There is some volume related indications. It's a better outcome after surgery in hemorrhagic stroke if the volume is 10 to 30. Less than 10 doesn't need any surgery for conservative treatment. More than 30, sometimes you go for surgery, but outcome is not so good, especially in the elderly people. In massive hemorrhage, where there is 60, in 30 days, mortality is about 91%. In massive hemorrhage, more than 85, patient may not survive even after surgery. So other indications are failure of medical management and persistent elevated ICP. In modern setups, there is setup is there for assessing the ICP. So we can bedside we can assess the ICP also. Other clinical parameters is rapid deterioration, and for young patients, especially less than 50, they tolerate surgery better than the elderly patients, and we'll go for surgery in hemorrhagic stroke. Other location-wise, in favorable location, it is lower and is outside the external capsule and in non-dominant hemisphere. So early intervention, it is more beneficial. Surgery after 24 hours of the onset of symptom or deterioration may be of less benefit. Cerebellar hemorrhage, some GCS score is 14 and less than 4 centimeter, we can observe in some time. But if the GCS is more than 13 and the hematoma is more than 4, we should go for cerebellar hemorrhage, for surgery. Poor prognosis is in hemorrhagic stroke, that is in putamenic hemorrhage, lesion larger than 140 millimeter in one slice, thalamic hemorrhage, maximum diameter lesion of more than 3.3 centimeter, and cerebellar lesion larger than 3 centimeter. Surgical intervention. To combat life-threatening raised ICP, we should go for decompressive craniotomy. To divert interventricular content, that is CSF and blood, external ventricular drainage. Craniotomy and endoscopy for removal of intracerebral hematoma, and for clipping, wrapping, or coil aneurysm to prevent repeat in case of subarachnoid hemorrhage, which is intracerebral hemorrhage, and excision of AVM malformation. This is surgical intervention. We should go from surgical site for intracerebral hemorrhage. Some decompressive craniotomy, the massive hemorrhage leads to mass effect, raised ICP, brain herniation, and death. So decompressive craniotomy is a surgical technique aiming to open closed box represented by the non-expansible skull in case of refractory intracranial hypertension. It makes about 70 ml extra volume in a typical trauma flap and decompressive craniotomy. For bone, 40 ml, for dura or duroplasty, 30 ml. It is important. There is some how we do decompressive craniotomy or hemiocraniotomy. It is 9 by 12 centimeter craniotomy, frontal, parietal, occipital, and temporal including. And dura should be cut in this way, and we'll go for duroplasty. Dural layer separation, duroplasty. And other technique is there, steroid technique. In some patients are on aspirin. So for big surgery, it leads to further hemorrhage. So in that case, stereotactic intracranial hemorrhage aspiration is other good technique. By stereotactic frames, we can do ultrasonic aspiration, high pressure fluid irrigation, endoscopic aspiration, or catheter aspiration with injection, subsequently thrombolytic agent, tissue plasminogen activators. This is some presentation of stereotactic aspiration, making a small bar hole without doing a large flap. In a specific case, we can go through brow and without injuring the brain, we can remove the clot. This is endoscopic aspiration of the hematoma. Some easy method is there, invented by one of the Indians. He used to use endotracheal tube split in the middle, and he's using like this as a metallic trocus, the plastic tubes, very simple. For interventricular hemorrhage, we should go, it leads to obstructed hydrocephalus. If it produces obstructed hydrocephalus, we should go for external ventricular drainage, and followed by, sometimes it is needed, if it is not improved well, we should go for a shunt. So for spotted stroke, it is very important to be fast. That is to identify whether is in the home, the patient has some symptoms, the face is drooping, or arms is weakening, there is an arm weakness. This is the symptom or primary symptom to have to identify a patient at home. The patient is having a stroke with speech difficulty. That is FAS, and this is the time to transfer the patient to hospital. So finally, it will be the fast. The fast, we move the patient to the hospital or nearby medical centers. The patient will be treated as early, and we can salvage the infarct brain, and we can help the patient, and finally will help the developing our national economy. Thank you all.
Thank you, Professor Dhiman Chaudhary, for your nice and elaborative lecture. By this time, our panelist, Professor Sheikh Sader Hossain sir, is joined with us. Welcome, Professor Sader Hossain sir.
Thank you.
Our next speaker is Dr. Lieutenant Colonel MD Alamin Saleh. He will present to us a very interesting topics. Previously, we think pediatric population has immune to stroke, so they have no chance of stroke. But reality is different. Pediatric population also faces a stroke, and it has some modern treatment. Welcome, Dr. Alamin Saleh. Please start your speech.
Hello, everybody. Am I audible?
Yes.
Okay. Respected teachers, especially our President of Bangladesh Society of Neurosurgeon and VC, Professor Kanti Gurwa sir, Professor Musharraf sir, Professor Sadeh sir, and other learned audience. It's good evening to everyone. I'm thankful to the organizing committee for inviting me to say something about this pediatric stroke and its subject. In fact, by this time, my previous speaker has elaborately mentioned about the definition, burden, and the management options of stroke in general for the adult groups. So I will focus on specifically on the pediatric age group. Most of the contents I tried to take, I have tried to take in from management of stroke in neonates and children, a scientific statement, American Heart Association or American Stroke Association, that has been published on 28 January 2019. Because I have to find out what is the update. That's the thing. Stroke can occur even the child is in utero, in the mother womb. So it can occur in the utero, but for definition purpose, perinatal stroke and childhood stroke has been clarified as like stroke occurring from 28 weeks gestation to 28 postnatal days of life, and stroke occurring after 28 days to 18 years of age is called childhood stroke. I will mainly focus on this age group. I just simply lay out of my today's presentation. A childhood stroke is important because it is an important cause of acquired brain injury for newborns and the children. Stroke can occur in seemingly healthy infant, children, and adolescents. Despite the plasticity of the developing brain, stroke in children carries substantial morbidity, and it's relatively rare than adult one, though the cause may be arterial or venous stroke. So, for discussing about the pediatric stroke, I will share few of my problem-based cases that, according to the pathophysiology of the childhood stroke, that it can occur as like that of the adult one. First of all, if you can see this scan, is this is one of the twin of the recently surgery that we did, the craniopagus twin. The one baby who developed spontaneous ICAs 6 weeks after the separation surgery. Of course, this baby was suffering from sepsis and coagulopathy. So we thought that this the cause of the spontaneous ICAs. You can see here is the post-op day 3 and post-op after 6 months. This is another case, this interesting case. This baby, when she was around 5 years, she underwent medulloblastoma surgery, and followed by she was treated with chemotherapy and radiotherapy. So one day we suddenly noticed that she has become right-sided hemiparetic and with slurred speech. And though the baby was tumor-free for last 5 years, so we did the MRI, and CT angio. I didn't input all the things. You can see here is the right ICA is here, but total occlusion of the left ICA territory and some collateral formation. So we counsel the condition with the parents. They are happy with the patient's clinical outcome, and they want to continue the medication and physiotherapy. This is another interesting case. This is a 10-year-old boy who is a schoolboy. He had episodes of headache, and he was about to leave the school. Otherwise the patient was neurologically intact. So the radiological imaging, you can see here, there is a mass effect in the left temporoparietal frontoparietal region with mass effect, and later the suspected case of ISO-SOL. But we did the angiogram, which shows an aneurysm in the M3, M4 region. So the patient underwent craniotomy, and you can see this aneurysm was thrombosed and which was moved like a tumor. And the post-op MRI, there is no neurological deficit, and the angiogram looks okay. We presented this topic in the 9th conference, BSNS conference. This is another case, is a spontaneous IVAs in a premature neonate, most likely maybe germinal hematoma, and we treated it with EVD, but the patient doesn't require any shunt. This is another case. Recently, just this patient is a 7-year-old boy who is presented with hemiparesis, and we did this scan and angiogram. You can see most likely his right ICA, terminal ICA is stenotic, but still we are keeping him for the further evaluation for Moya disease, and we will go for DSA and other radiological investigation. This is another case. This is a 15-year-old girl who presented with sudden headache and altered level of consciousness, this case was also involved by our neurologist colleague. The scan, you can see in the CT scan, the ICAs with some edema and mass effect, and also the venogram shows there is superior sagittal sinus thrombosis. So this patient underwent medical management, and ultimately she recovered well. So these are the few cases that depicts the etiology of the stroke in childhood is like that of the adult one. So if I go through the burden of stroke, you can see that in children, ischemic stroke and hemorrhagic stroke prevails, but unlike that of adult, where ischemic stroke is more than 85%, but in children it's around 55%. in our center, I discussed with my pediatric neurologist. She told me that it's about 70%, 30% like this. So ischemic stroke affects an estimated 1 to 2 in 1 lakh children, non-neonates annually in Western developed countries. Incidence varies by age and sex. It's highest in infants and children less than 5 years of age. Black and Asian children have a higher incidence than white children, maybe due to the risk of sickle cell disease. And hemorrhagic stroke in children can be intracerebral IVAs or subarachnoid hemorrhage. And it's as I have told, it's almost 50% of the pediatric stroke. There is a different entity in case of this recurrent stroke that happens in the pediatric age group. It is about stroke recurrence around 6.8% at 1 month and 12% at 1 year with most children with antithrombotic treatment. Just the overview of pathophysiology of stroke. That is in case of infarction or acute ischemic stroke that can happen from the arterial ischemic stroke or venous infarct. In arterial ischemic stroke, that may be in situ thrombosis or thromboembolic manifestation or hypercoagulal states. And venous infarction is not frequent than that of the arterial ischemic stroke, but it may turn into infarction or hemorrhage and maybe serious effects to the patient. So clinical features, there's that of adults. This can be as localizing symptoms or non-localizing, like hemiparesis, speech or language disturbances, vision disturbances, bradycardia, and children that present with non-localizing symptoms, the headache, altered mental states, seizures, and at stroke are more common in children than adults, and about 25%, especially in those that less than 6 years of age. Clinical presentation varies according to age, setting, or the stroke subtypes. There is some few special situation that occurs in child stroke scenario, that stroke that in cardiac diseases. So cardiac acute ischemic stroke resulting cardiac disease occurs in the inpatient setting than the outpatient setting and involves younger children with a median age of 6 months to 3 years. These children present with seizures in up to 40% and hemiparesis in 36% and clinically covered in 14 to 40%. So there is a study that Brown et al. Found that in this stroke patient usually present with abrupt onset of symptoms rather than the arteriopathy presentation, or maybe starting of fluctuating presentation. This another one is the Moya type arteriopathies. This is important because nowadays we could find a good number of cases, maybe due to the early presentation, awareness of the parents and the coming to the doctors, and also the investigation facilities that we have in our hand. So children with Moya type arteriopathies are distinguished by the prevalence of transient ischemic attacks and a large burden for infarction. The TIA may be single time or maybe multiple times. The signs symptoms includes like that of the stroke, like hemiparesis or hemisensory deficit, and often with chronic headache or occasional seizures. Imaging at the time of initial diagnosis has shown evidence of prior silent seizure in silent infarct around 52%. In another cohort of 60 children with Moya who initially presented with TIA, 55 children, that is around 92%, had recurrent TIAs and 23% went to the infarct. Severity of the Moya arteriopathy at presentation corresponded to the risk of subsequent strokes. Childhood stroke have a wide range of differential diagnoses. So child neurologist is our good friend who can help us to find out those cases, those patients who are amenable for surgical intervention. So but side by side, we have to exclude those cases with complex migraine like focal or hemiplegic migraine, other focal brain pathologies. Stroke mimics can include encephalopathy related to hypertension, intracranial infection, tumor, drug, pseudotumor cerebri, inflammatory diseases, epilepsy. So these group of disorders, obviously the child neurologist helps us to exclude those cases for management purpose. Actually, the diagnostic workup, apart from the clinical features, it aims to diagnose the stroke itself, whether it is infarction or hemorrhage, and to find out the underlying cause of the stroke. So, and also the management protocol that requires CT scan, MRI, either CTA, MRA, or DSA, some form of perfusion study, sometimes the transcranial Doppler. So I'm not going in details of this one. This is the headline. Simply management outline like acute stroke management, definitely is the emergency room management with the aim to maintain the good perfusion to the brain. So and the specific treatment, it is directed towards the cause and towards the pathology of the lesion, whether we'll go with the medical treatment or surgical treatment. So medical treatment either form aspirin, anticoagulant, or antiepileptic. But surgical treatment in selective cases, mechanical thrombectomy is more common in adult group than the pediatric, but pediatric group is also nowadays there for large vessel occlusion. It's a suitable case for mechanical thrombectomy, sometimes in the form of decompressive craniectomy to combat the raised ICP. And very important was the cerebral revascularization. This is especially for the moya disease. Say direct or indirect cerebral revascularization is very emerging and is promising for selective cases, and definitely those patients who is having this occlusive vascular disease, doing the cerebral revascularization, we can prevent the recurrent stroke and prevent the morbidity from the disease condition. And the thing that we have to keep in mind that whatever treatment we give to the patient, the final thing is that stroke rehabilitation. This is very important, especially physiotherapy, occupational therapy, speech therapy. So this inductive or comprehensive stroke rehabilitation is very important for the final outcome of the patient, because you can see the patient may come to us with the effects of stroke with hemiparesis, hemiplegia, or other problems. So stroke rehabilitation is a important topic that we should not forget. I will finish here with my take-home message or points that potential causes of childhood stroke are diverse and often differ from seen in the adults. Diagnosis of acute ischemic stroke is particularly challenging in children because of a high number of stroke mimics. As I have told in the differential diagnosis, reperfusion strategies, either recanalization or revascularization, have been used but remain unproven in children. That I have already told, cerebral revascularization has potential benefit in selective cases of childhood stroke. And finally, the nationwide comprehensive stroke care, not only stroke care, stroke ready centers are required in peripherals and in the center, especially in the Dhaka city, the big institutions where comprehensive stroke care service or facilities can be provided with the help of the trained doctor, trained nurses, trained manpower. And I think with these legends, neurosurgeons of Bangladesh that we have in our hands, we'll be finally able to have these facilities in our country very soon. Thank you very much.
Thank you, Dr. Alamin Saleh, for focusing to a interesting topics of stroke. Now I invite Dr. M.D. Shafiqul Islam, Associate Professor, Dhaka Department of Neurosurgery, Dhaka Medical College Hospital. He will say something on cerebral aneurysm at different location, endo and microvascular solution. Dr. M.D. Shafiqul Islam, please.
Hello.
Yes, audible.
Sorry, I was muted. Thank you very much for giving me opportunity to say something on this very World Stroke Day 2020 on treatment of aneurysms. First of all, I'd like to congratulate the new elected members of Bangladesh Society of Neurosurgeons, including our beloved Professor Pranab Kanti Barua sir, Honorable VC Bangabandhu Sheikh Mujib Medical University, and he has been elected as President of Bangladesh Society of Neurosurgeons. With permission of all dignitaries and panelists and moderators, I'd like to start my talk. So decision-making factors for the treatment of aneurysms. The first point is patient's factor. The second one is center factor, which center I'm going to treat. And the third cost is cost factor, especially it is very important for Bangladesh. So we should have an alternative. And next generation neurosurgeons should be prepared for bypass. The patient factor that includes morphology of the aneurysms, that is size, site of the aneurysms, neck-body ratio, whether it is dissecting or secular, etc. And center preference, it means the center, the facility of that center and expertise of that center that may determine in the decision making. In 2 or 3 slides, I'd like to run on basics of coiling, because this is the surgeons forum, so it's better they should know few points on coiling. In the first month after coiling, thrombus formation occurs, fibroblast, macrophage, and active inflammations are there. Then subsequent months, the aneurysm excluded from the circulation by formation of neo-intimal layer within the neck, and it is discontinuous. And inflammatory cells are largely absent here, and subsequently neovascularization starts to occur, and that is something alarming, especially in case of dissecting aneurysm. That is the cause of recurrence in case of dissecting aneurysm. And we know generally if the coil is densely packed, it means only 25% of the aneurysm volume is impact, and 75% is packed by thrombus. And basically, the cause of recurrence after coiling is growth of the aneurysm itself, poor thrombus formation, continued transmission of blood pulsation, and lack of neo-intimal formation and formation of neovascularization in the dome. I'd like to pass 3 slides on carotid aneurysms. Secular aneurysm. For secular aneurysm, clipping surgery is well done by majority of the neurosurgeons in Bangladesh, but in case of non-branch aneurysms, dissecting aneurysms, and blood blister aneurysms, the story is a bit different. You see this IC dorsal aneurysms, non-branch aneurysms, because of flow dynamics, flow starts here and usually it gets stuck here. So turbulence of flow is there. Because of flow dynamics, usually recurrence rate is very high, especially in this area after coiling. And in case of dissecting aneurysm, it is a wall disease. The simple aneurysm treatment does not cure the disease. Coiling or clipping is not the solution. Either endoluminal flow diversion reconstruction or bypass is curative. If you see these images, the only option for this kind of diseases is vascular reconstruction. We treated this disease, small blood blister aneurysm supraclinoid. We treated this disease with flow diverter. You see, immediately after flow diverter, flow starts to reduce. Flow starts to reduce and is cured. So it doesn't take too much of time. Learning curve is there, but it is not that difficult. But only issue is the cost. We are trying to cut down the cost also. This is the story of Selina. She came to us with subarachnoid hemorrhage and vasospasm because of blood blister aneurysm. At that time, we didn't have a flow diverter. We just clipped the aneurysm. When we clipped the aneurysm, we thought that we clipped very well, nicely clipped, but the story was different. After 6 weeks, it recurred like this, notorious recurrence. And we had no other options but to occlude the proximal vessels. And you see the collateral from the contralateral side. The patient is still surviving with mild paresis, but is doing very good. This is story just like what Salek said. This is a girl of 12 presented to us with subarachnoid hemorrhage, IC bifurcation aneurysm, coiling done. This is follow-up CTA 1 year after. Patient is still doing very good. I think it's a case we did 5 or 6 years earlier. Sometimes clipping is difficult in 2 or 3 hands. For instance, in this case of IC bifurcation, posteriorly located aneurysm, we put 3 temporary clips. You see the aneurysm all around. We tried all about to secure the arteries and to occlude the aneurysm. But you see, when we clip, the tip of the clip gets stuck with the anterior cerebral artery. We tried it for many times, but we failed. Finally, what we did, we put 4th hand with Doppler in the anterior cerebral artery, and 3rd hand with the dissector in the anterior cerebral artery to make it straight when you put the clip. And finally, it was successful. This is PCOM aneurysm. It was coiled, the balloon assisted technique. You see very dense packing of the coil. It's very simple. It doesn't take too much time. This is one more coil, dense packing of the coil. You see distal part of the aneurysm. We didn't fill that part with much coil, but since proximal part of the aneurysm is densely packed, it is cured. The left-hand side is the complication and the right-hand side what we learned from the complications. So learning from mistake, we used less magnification. We didn't use temporary clip. It was a mistake. And I thought in this case, our study with the patients was inadequate. And during surgery, we didn't see the neck very well. So we had a torrential bleeding, devastating bleeding complication. Luckily, we could manage. So learning from this case, we changed the approach. Now, majority of the PCOM, we go pre-temporally. Vision is better. We can see the neck. We can dissect all the arteries. with maximum zoom. And that gives us better visualization in terms of artery wall morphology and clip reconstruction. And for FICOM, we use bayonet-shaped clip. And ECOM aneurysm is, to me, it is the most difficult among all aneurysms because there are a lot of variations. It could be anterior directed, it could be inferior directed, it could be superior directed, it could be posterior directed. We all know about it. And it could be bilobed or multilobed also. For surgical options, it can be pterional, it can be anterior hemispheric, it can be through dominant and non-dominant. And for endovascular surgeons, it usually needs some kinds of assistance, either balloon assistance, stent assistance, or Y stent assistance as well. Simply, I have a question. Usually, we prefer pterional, but if anybody of you travels in Japan or country like that, they usually prefer anterior hemispheric. Aneurysm like this through ECOM, I have a feeling, is this better to travel from anterior hemispheric or pterional? Somehow I feel anterior hemispheric should be better to treat this kind of aneurysm because it opens all the branches. For endovascular, if small aneurysm is also not difficult to coil if the neck is narrow. This is a case of balloon-assisted coiling, good coil compaction. This one is very interesting case. This true ECOM aneurysm. If we coil this part, aneurysm, the neck, small part in the neck remains open. So what he did, we coiled aneurysms along with the anterior communicating side. We separate the artery and the patient is cured. Simple coiling easy for relatively large size aneurysm, and framing is reasonably easy for this kind of aneurysms. Sometimes we find that brain is very tight, it is very difficult to travel to the carotid systems. What do? Do we abort? Sometimes we try modified Simpson's point to drain CSF. We can also do suck CSF from the carotid cistern. Just simply do durotomy along the sylvian fissure. Just what we do for CP angle surgery. You aspirate CSF, then the brain is very lax, then you do the rest. This case, what we thought, if we carefully study this CTA, though this A1 is dominant, if we see the fork, if we travel from the non-dominant side, we can easily visualize the fork and surgery should be easier. And that's what we did. We traveled from the other side. This is a temporary clip on the contralateral A1. Then we did the rest. We completed the clipping. Somehow we feel it is better if we can analyze the fork to choose our approach or the dominancy or non-dominancy. So MC aneurysms, it is commonly it is dissecting. Bifurcation aneurysm is very difficult to treat since it is close to surface in the sylvian fissure and no cisternal collateral is here. Simple on proximal temporary clip is good to control the flow. So we always prefer surgery should be the preferred option for MC aneurysms. So this case, 65-year-old lady, she had a lot of comorbidities in multiple aneurysms. We just put some coils to secure the aneurysm, and she was fine for 5 years. After that, she had another stroke and died. It could be due to rupture of this aneurysm. It could be due to rupture of another aneurysm in PCOM on the other side. You see, this case, we thought this aneurysm should be dissecting, and that's why we prepared for bypass, and we traveled accordingly. This is harvested STA. Nowadays, we do pterional craniotomy by single bar hole, just for understanding of residents. This exactly bar on the pterion. This is the lesser wing. They're traveling like this. This is exposure of poverty. This is M3. Bypass is being done here. Very good flow. Then it went to the aneurysm and it clipped reconstruction of that. But when we put clip, we initially thought that this frontal part of the M2 we cannot save, but we could save, and very good flow was restored. So this is pre-op. And this is post-op, very good reconstruction. We can visualize the bypass also. If the neck is narrow, coiling is also good for MC aneurysm. That's not here, but in this case, we had a complication. This is one of our initial case. Clot migrates here, and this vessel becomes stuck. This is distal MC aneurysm, M3 aneurysm. This is dissecting aneurysm, and one of the popular option is to put a drop of glue here in VCA and occlude this aneurysm along with the parent vessel, and that cures the disease. Vaginal drop, BSC aneurysms, we first treated without balloon assisted, but it recurred, and second time we did balloon assisted, and it's doing very good for last 3 years. And this is basilar top aneurysm. I think Professor Haradanda knows very much about this patient. It is this patient. This basilar is the only lifeline for this patient. These all are the MC. These all are the MC of this side. Probably this aneurysm is due to flow related, because this is the only lifeline. So we secured the aneurysm for now. Patient improved, and next plan could be the STMC bypass to increase the flow result. We didn't do it. This is an interesting case, basilar tip bilobe aneurysm. If you look carefully, he has a very good PCOM on the right side. You know, bifurcation aneurysm is very difficult to treat. There are too many devices already in the market, and there are too many devices upcoming to treat the bifurcation aneurysms. Since we didn't have many of them, what we did, we coiled this patient balloon assisted. This is balloon, and this is coil. During coiling, we intentionally occluded P1 segment, origin of the P1 segment on the right side, and we made the aneurysm side wall instead of bifurcation, and that cured the disease. This is V3 segment dissecting aneurysm. What we did, we just occluded the aneurysm along with the parent artery, and patient is cured. This is pica origin aneurysms. We coiled it. It can be surgically clipped also. This one is P2-3 junction aneurysm. This is dissecting aneurysm. We put simple coil, but I think stent assisted coil should be good option if you want to cure the disease. Patient is still doing fine. He's still under follow-up. And this last slide, this is post-op case of basilar chip aneurysms. And that is the end of my presentation. I thank you very much for your patience here. Thank you very much. Dr. Sudipto. Hello. Hello.
Yeah.
Thank you, Dr. M.D. Shafiqul Islam, for your nice presentation. And now this is the time for panel discussion. I first invite Professor Sheikh Sader Hussain, former professor and departmental head of neurosurgery, National Institute of Neurosciences and Hospital. Professor Sheikh Sader Hussain, sir, please.
Stop sharing.
Yeah. Yes, looking for it.
Can you hear me?
Yes, sir.
Thank you very much, Dr. Sudipto. My Honorable VC Professor Konakkanti Borua and the President of the Bangladesh Society of Neurosurgeon and the newly elected Dr. Joinul Secretary of the Bangladesh Society of Neurosurgeon and all the participants and the speaker who have given the lectures on the three topics. Actually, I think it's a very good presentation, starting from about the pathophysiology and management as a whole of the stroke, whether it is ischemic or hemorrhagic, which is given by Dr. Dhiman Chaudhary, Professor Dhiman Chaudhary. I think it's a very good outline he has given us and he has shown in his presentation. And after that, the stroke about the pediatrics age group, which is given by the Lieutenant Colonel Salek. And he has also shown how we differ in pathophysiology and its location. And in case of pediatric stroke, it differed from the adult stroke from pathophysiology, and also the hemorrhagic stroke and ischemic stroke is more or less 50-50 in case of pediatric age group. But in adult, it is more or less a bit different because ischemic is about 80% and 20% is hemorrhage. And Salek has also give the management and diagnosis and how it mimic with the other disease. That was also very good presentation. And after that, the surgical management, mainly whether by microscope, I mean microsurgical or endoscopic surgery of the aneurysm, the account given by the Dr. Shafiq, and he has given his good presentation and showed a good video. I think to deal with the aneurysm and this vascular pathology, this is the time some neurosurgeon, at least who are junior or resident, they should be dedicated enough to deal to that way. Otherwise, it will not be possible to deal with the aneurysm, different type of aneurysm, complicated aneurysm, by simply doing all things in a same manner. So we should be dedicated enough to do, and when a surgeon will do, he will do aneurysm with all dedication. Otherwise, he will not be able to gather his skillness about management of this aneurysm because it's a vast chapter and at the same time it's a complicated one. Only there is that is his dedication, and if he give his time to this, then he can achieve the skillness. And again, the thing is that about the stroke, I think every stroke patient, mainly the hemorrhagic stroke patient, should be directly admitted under neurosurgery. And also the ischemic patient who has indication like massive infarction, MC infarction. And all stroke patients should be under neurosurgery. And after that, if there indication, they will be referred to neurologist. So in the with this few words, what I want to tell, I am thanks to all the speakers and all the participants, and again thanking the committee for arranging such a nice presentation. Thank you very much. Thank you very much.
Thank you, Professor Sheikh Sader Hossain sir, for your nice panel discussion. Now I invite Professor ATM Mosharraf Hossain sir, Chairman, Department of Neurosurgery, Bangabandhu Sheikh Mujib Medical University. Mosharraf Hossain sir, please.
Sir should unmute.
Hello, can you hear me?
Yes, sir.
Yes, yes.
Yes, okay. Thank you, everybody. It's my privilege to be here as a panelist on the occasion of World Stroke Day celebration by the Bangladesh Society of Neurosurgeons. Actually, the World Stroke Day is celebrated since 2004 in the rest of the world. But in this part, in Bangladesh, actually, with the surgeons, this time we are celebrating the day by the occasion. Particularly, I must thank and appreciate the endeavor taken by our Honorable VC and our newly elected President, Professor Konokanti Borua sir, for the initiative by the surgeons to be part of this stroke management. And actually, today's webinar is a milestone for our surgeons, especially this forum, to be actively involved in the stroke management endeavor. And today's webinar, there's 3 speakers with us. First speaker, Professor Dhiman Chaudhary, is elaborated and nicely touched the every corner of the stroke epidemiology, the management, and the recent protocol for the stroke management, particularly in this recent times, and the role of surgeons, particularly in case of hemorrhagic stroke and the massive ischemic strokes management. And he also does the every corner of the, particularly the demographic data and the other aspect of the stroke and role of surgeons. He highly scored the role of surgeons, particularly in the management of the stroke patients. And the second speaker, Lieutenant Colonel Saleh, actually particularly a stroke in the pediatric age group. The common belief that the pediatric age group or younger age group is usually spared from the stroke catastrophes, but it is not really. The scenario is quite different with the advent of the particularly awareness and the other diagnostic and investigating facilities. We are really diagnosed particularly the stroke events in the pediatric age group, and especially there are some in the neonates, and particularly the Maya arteriopathies and others stroke problems are there. And Dr. Salek is nicely represented some cases and their management in the pediatric age group. And we must be aware of this, particularly the impact of a stroke and management protocols in this pediatric age group. And thirdly, I must really be amazed and really feel good that as usually the Dr. Shafiq is nicely he's covered his topics, particularly the aneurysm and other hemorrhagic strokes. and the expertise for the management of stroke patients, particularly in aneurysm and other things with side by side with the endovascular expertise. So at the end of the session, I must congratulate the new committee that they have timely taken the topics of this stroke management, that we must be aware of our role in the management of stroke patient. And our neurosurgeons, they are actually playing a pivotal role in the final management of the stroke patient, and we must be engaged ourselves along with our neurologist colleagues in a better and a decisive way. And thank you again, everybody, for these patients attending this webinar at a late night, I must say. I must again thank you, the organizers, for giving me the chance to be an honored panelist in this webinar. Thank you very much. Thank you, everybody.
Thank you, Professor A.T.M. Mosharraf Hossain, sir, for your nice panel discussion. Now I invite Professor Konok Kanti Borua, sir, Honorable Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, President, Bangladesh Society of Neurosurgeons. Sir, please.
Sir, can you please tell me the which ID sir is using? I'm not finding him. Shripto sir?
জানুল ভাই, স্যার কি আসছেন?
স্যারকে তো পাচ্ছি না।
ফোন করো।
If sir is not available, then Senior Vice President Professor Sheikh Sabir Hossain sir can represent Professor Konok sir at that moment. So I'll try again.
হ্যালো, হ্যাঁ স্যার একটু, স্যার আইডি দিলেই হবে, ইয়ে লাগবে না, পাসওয়ার্ড লাগবে না, আইডিটা আমি বলি, স্যার আপনি একটু দেন। স্যার তাহলে আপনি একটু পারমিশন দিলে মোশাররফ স্যারকে বলি স্যার কিছু বলার জন্য। ইয়েস স্যার। আচ্ছা, ইয়েস স্যার, ইয়েস স্যার। মোশাররফ হোসেন স্যার।
Yes, I am. Dr. Sudipto, please.
স্যার,
Can you hear me?
ভিসি স্যার কোনোভাবেই কানেকশন পাচ্ছেন না, উনি আপনাকে রিকোয়েস্ট করছেন যে ওনার পক্ষ থেকে আপনি প্যানেল ডিসকাশন এবং ক্লোজিং রিমার্ক করার জন্য।
Okay, thank you to be here again. Can you hear me, Sudipto?
Yes, sir.
Yes, okay. Again, I am coming back to represent our Honorable VC Sir and the President of the Society. It's my mission. I must say that we, the neurosurgeons, are now taking the more part and more, I must say, more aggressive in the management of stroke patients, particularly hemorrhagic stroke and other things. And they are side by side. They are our dedicated group is interested in the management, particularly endovascular procedures they are taking, and it is our pleasure to observe that our colleagues are doing they are with separate entity and cath lab in the Dhaka Medical College Hospital and also in the National Institute of Neuroscience and in the BSMMU. They, along with the neurologist and also independently, they are doing the endovascular procedures and other things. And I must say, at the end of the day, that now the time to develop the super specialties and other things to achieve the optimum benefit and optimum result for our stroke patients. So on the eve of the World Stroke Day, we must be more, I must say, more aggressive and more sincere and more dedication, with more dedication to serve our patients and our nation regarding this stroke management. And along with neurologists and our rehabilitation forces, particularly our physiotherapists and physical medicine colleagues, we must, as you see, that the stroke patient, they have need a much rehabilitation and other, and also they are very a burden to our society. So we must minimize this sort of burden. And at the end of the day, I must say that it's my pleasure to say something on behalf of our Honorable VC and the newly elected President, Professor Konakantri Borua. And I think if there is no any question and answer session from the audience and also from the presenters, if there is no issue left, then I must congratulate the organizer and the newly elected committee of the Bangladesh Society of Neurosurgeons to arrange such an lively webinar. And I hope the society will contribute more effective and more vividly in near future. Thank you everybody for patients attending and patients hearing. Thank you.
Thank you everyone. With a hope that we can organize this type of webinar in a regular interval from now on. So if everybody agreed, we can close now.
Thank you.
Yes.
Thank you everyone.
Thank you everybody.
Thank you, sir.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe.